Tashia, you can get started whenever you're ready.
Awesome. Thanks, Erica, for the warm welcome. And hi, everybody. I see, some familiar names in the guest list, some people from UBC and some people I haven't met, but welcome everybody. Really excited to be here chatting in the MAPS Canada Research Room. So let me just share my screen here. We can get going. Okay. All right. That looks like it is working for everybody. Great. So yeah, I'm very stoked to be here to share a bit about some of the cool research that we're doing out here in Kelowna, BC. Like Erica said, I'm a Mac alumni. For the record, even though I moved out here to do my PhD, I do miss Hamilton. Loved McMaster and loved living there. So hopefully I can come back and visit sometime soon. So yeah, I'm just a little bit of background about this project. It's quite the story, kind of how we got this study going. So this is a pilot project, and we don't have data collected yet. So if you read the abstract, you'll see that we're still in sort of the startup phase, and we have been for about 2 years. It's taken us to get this thing going, but we are just about going, and it's really exciting. But just to share with you, anyone who isn't a part of like trying to get a clinical trial going, it's a lot of stress, it's a lot of ups and downs, there's a lot of uncertainty. Right now, it's very difficult to get the funding, I would say, is the hardest part. And has been the part that's held us up the most is getting funding in place to do it, as well as ethics approval and, of course, government regulatory approval, which, funny enough, has been the easiest one of the three to get, which is not what I expected when I started this. So when I started out on this project, this was originally supposed to be my PhD dissertation project. And for anyone who is contemplating doing a clinical trial for the dissertation, don't unless you have a really solid backup plan. So I learned an interesting lesson about timing, and that's, trying to do a dissertation project on something with so much uncertainty and so much red tape to get through. You got to be flexible, be willing to pivot. So this is now sort of a passion project. I'm doing my dissertation on something else. But we're very, very fortunate to get this thing going. So without further ado, so I'd like to start by acknowledging that I live and work in Kelowna, British Columbia, at the UBC campus, Okanagan. The campus is situated on the traditional, ancestral, and unceded territory of the Syilx Okanagan peoples. I'd like to express my deepest gratitude as an uninvited settler to these lands, that I'm able to live and work here, and a deep thank you to the Indigenous people who have taken care of these lands for millennia and continue to do so. Our research team is committed to supporting conservation efforts related to preserving the biocultures associated with plant medicines, as the roots of psychedelic therapy go back to traditional Indigenous practices. In terms of conflicts of interest, I don't have any. I'm financially supported by other means while I'm doing this work. The study itself was initially started by the help of Entheotech Biosciences, which is a local startup company here. And originally, they intended to fund the entire study through an unencumbered grant. Unfortunately, we weren't able to make that a reality without having some perceived conflicts of interest. So that set us back for a while. We ended up having to spend some time finding another funding source. And by a wonderful turn of events, we connected with Melissa Etheridge, who is a rock star singer-songwriter, who, through the loss of her own son to opioid addiction a few years ago, through her grief and compassion for this work, she started a nonprofit organization called the Etheridge Foundation, which seeks to provide funding for projects like ours that are seeking to use plant medicines to treat opioid use disorder. So it's through the generosity of the Etheridge Foundation and Shinemaker Foundations that our work is fully funded. And they have also provided an additional 5% contribution to go directly to the Indigenous Medicine Conservation Fund. And if you're not familiar with that organization, I suggest you check out the great work that they're doing. So big thank you to Melissa. We're so happy to have her and the team and her team on our side. Today I'm gonna tell you a bit about the study, right? So tell you why we're doing it. Why do we think this is a good idea? And in particular, why are we wanting to treat people with chronic pain? And why psilocybin as well. So then I'll show you what our study design is like. And I'm really looking forward to chatting with you directly after and have an open discussion. So to introduce you to our study team, these are the lovely people that are working on this trial. And unfortunately, Dr. Johan Forster and Melissa Rowe, I just don't have pictures of them, but they are certainly a big part of the team as well. So the qualified investigator for the team is Dr. Francois Liu. He's a interventional pain specialist and physician here at the Bill Nalems Pain and Research Center. He's the physician for our study as well. The primary investigator is Dr. Zach Walsh, who is my graduate supervisor. He's an advisor to MAPS Canada and a prominent researcher and expert in the psychedelic science field. He recently provided expert testimony to the Canadian Senate and has been instrumental in getting their support for increasing access to psychedelics for veterans in particular. We have a stellar group of therapists on board, clinical psychology PhD students, as well as a very experienced data management specialist and myself. So about our study, why are we doing this? Let's situate ourselves in the opioid crisis. So we're now in year 7 after the opioid crisis was declared in 2016. The situation has only gotten worse with a 91% increase in the death rate attributable to opioids. Since the start of the pandemic, there's a lot of factors that go into this, and there is no one issue that needs to be addressed. So, of course, the drug supply has become increasingly toxic, but we also are having worsening mental health and less access to effective treatment, social isolation during the pandemic, and as well as sort of a long-standing issue with overprescription of opioids for chronic pain. So we can't address all of these, but our team is hoping to get at that sort of last risk factor there. If someone has their microphone on, I'm just wondering if you could mute it because I'm hearing some background noise. I appreciate that. Okay. So chronic pain basically is a huge problem in Canada. Over the course of the lifespan, 1 in 5 Canadians can expect to suffer from a chronic pain condition. It places tremendous burden on our financial systems, our healthcare systems. Second to the US, Canada has the highest rate of opioid pain medicine prescribing. And this is largely attributable to a period between 2015 and 2012, where there was a massive increase in opioid prescribing, which directly contributed to the opioid crisis. Health Canada, in response to this issue, published guidelines that basically recommends that physicians do everything they can to reduce their prescribing of opioids and to reduce the amount of opioids their existing patients are on. So in terms of opioids as pain management, I think it's important to note it's really effective in the short term. It's great for after surgery. It's good for cancer-related pain and palliative care. Where it's used more and is less effective is in managing chronic non-cancer pain. About 70% of people who are on long-term opioid management for chronic pain don't actually get effective pain management from it in the long run. And they're at higher risk for things like overdoses, developing an opioid use disorder, and having like accidents like falls and decreased quality of life. So in terms of the prescribing guidelines, Health Canada recommended 2 things. One, that patients on a high dose opioid therapy should taper to what's considered the lowest effective dose. Many of these patients are on doses that are much higher than what's recommended to be low risk. So it's recommended they come down or they discontinue altogether. They also recommend that those who have tried to taper with their physician and have failed, and by this we mean they might have started to reduce and then found they couldn't handle the pain symptoms and kind of went back up to an unacceptable level of opioid use. These people are difficult to treat and should receive intensive multidisciplinary treatment. They recommend things like a inpatient substance use treatment kind of setting.
I didn't get that.
Oh,
Could you try again?
sorry, my watch is, thinks I'm talking to it. So what does opioid tapering look like? So physician supervised opioid tapers tend to be very gradual over a period of time. So it's basically people meet with their doctor regularly and they gradually reduce the amount of opioids they're prescribed. It's actually very challenging to do for a number of reasons. So they have to manage withdrawal symptoms, cravings, and of course, the chronic pain condition is still present. And I should mention some of these pain conditions are things like chronic migraines, chronic back pain, musculoskeletal conditions, fibromyalgia, stuff like that. So really debilitating if it's not well managed. Unfortunately, physician-supervised opioid tapering has a really low success rate. Less than 50% who attempt are successful, and according to research that reviews patient records, the dropout rate's about 40%. So it's difficult for people to tolerate, and we need to find a better way. Multidisciplinary treatments, so situations where people need more intensive care, are very effective. They're considered the gold standard for treatment-resistant opioid tapering. However, they're not very accessible. They're either very expensive, far away from where people live, or publicly funded programs have extremely long wait times. And research has found the average is about 2 years or more. So you can imagine once people are already ready to quit or get help, to hear that you have to wait 2 years is discouraging. So let's talk about why the taper process is so difficult. So when we think about opioid withdrawal, the peak effects are typically physical and they occur within the first few days. So let's say at 72 hours, you get kind of the worst physical effects of withdrawal. The good news is that doctors are pretty good at managing the physical symptoms. You can get medications that help, a medically supervised detox, that kind of thing. The real issue and where most people tend to relapse to problematic use is in the longer term of withdrawal. So it's that, several weeks to a month later. And you'll notice these withdrawal symptoms are mostly psychological. So we can also think about this as perhaps like a void that the opioids are leaving, and also add to that chronic pain symptoms as an issue that's unaddressed, right? So we are not doing well at meeting the psychological needs of chronic pain patients. Research has looked at non-pharmacological approaches. So these can be things like massage, acupuncture, cognitive behavioral therapy, mindfulness, physiotherapy, and reviews. So Cochrane reviews of randomized trials have actually found that these are ineffective as standalone treatments for opioid tapering. They recommend that because they're not great by themselves, they should be paired with some kind of pharmacological or medical treatment. And this is getting back to that idea of a multidisciplinary approach. And because I'm talking to MAPS Canada, I don't think it's any, mystery what we're thinking could be a potential solution here. We are wondering what role psychedelic therapy could play in this. What are some of the unmet needs that we could be looking at? So we're wondering, can psychedelic therapy help to provide that psychological support during that difficult time of opioid tapering? Could it be sort of this ideal synergy between a psychological and a pharmaceutical intervention that we're missing? And could it reduce some of the systemic barriers like access, cost, efficient treatment? And I'll be the first to say I'm really skeptical about this one because our access to any psychedelic therapy right now is so limited. But I'm hoping down the road that this could be something that would at least be a more time-effective approach. And lastly, could psychedelic therapy reduce some of the intrapersonal barriers? So these are some of the psychological vulnerabilities that might make someone have a difficult time with taperings. That could be underlying depression, anxiety, or vulnerabilities towards addiction. When we think about opioid use and chronic pain, what are some of the reasons why this might work? Well, for one, other plant medicines have been used to treat opioid use, and we've got anecdotal evidence, and we have some clinical trial evidence. For instance, LSD was extensively studied in the 50s and 60s for alcoholism as well as opioid use. There's lots of reports about the use of iboga or ibogaine, especially for opioid use, but it hasn't been studied with psilocybin. And I'm not saying we should stop looking at the other compounds, but there should be a menu of options. Perhaps for someone, iboga is not a great option in terms of their medical safety, but psilocybin could be, you know what I mean. And psilocybin so far in clinical research appears successful for other substance use disorders, other forms of dependence. And there's been increasing calls from the scientific community to try it with opioid users. Another thing to consider is that perhaps this idea of psychological flexibility could come into play, right? So allowing someone to maybe stop avoiding some of the symptoms associated with pain, to maybe have different perspectives on their pain, could actually improve their chronic pain symptoms and reduce the need for opioids. Now, I am aware that kind of since starting this work, there have been other trials that are in the works that are using psilocybin to treat opioid use disorder. And I believe those are more geared towards getting people off of something like heroin or fentanyl and onto like an opioid agonist treatment like methadone or buprenorphine. So it's great to see that there's multiple pathways that are being investigated here. I also want to talk a bit about, from the brain perspective, why we think this might work. So with psychedelics, we know their primary mechanisms are through the serotonin receptors. And these receptors are most concentrated in areas of the brain that are associated with higher order processing, in particular, the default mode network and the frontoparietal network. Now, these two networks normally talk to each other, right? And the connectivity between them has been identified as dysfunctional in a number of the disorders that we're interested in. So with addiction, depression, PTSD, OCD, anxiety, and chronic pain, we see similar dysfunctional connectivity between these networks. In sort of more layman's terms, what this actually translates to, this rigid thinking, really is this repetitive automatic thinking, compulsive behaviors, and rigidity. So the question is, can we use psychedelics as a tool to help rewire these neural pathways and perhaps allow people to have more healthy connectivity between those parts? Theoretically, from the neuroimaging study findings so far, it looks like we possibly can. And that's another reason why we want to try this. Now, I don't know how familiar people here are with these studies. I won't spend too much time on it because I think there's been a lot of talk about these pilot studies for alcohol dependence and tobacco dependence. But just to illustrate that some other pilot studies have found really interesting, compelling findings. You know, if we think about addictions treatment, the relapse rates are really high. I've worked in rehabs for many years. I've worked in outpatient clinics. The relapse into heavy drinking or heavy substance use is it's the majority. So to see findings like this, where after a couple doses as part of a structured intervention, you know, you see sustained decreases in drinking, and that the degree of spirituality that's experienced during the sessions predict better outcomes. And that's been an area of interest. So we are measuring in our study the mystical experiences too. Similarly for smoking cessation, the Johns Hopkins research, so 2 or 3 doses, and 80% of participants remained like biologically verified smoke-free at 6 months. And if you ever worked with smokers, this is unheard of. So really, really encouraging results. Obviously, there's some mechanism for the addictive process here that's important, and reason for us to potentially try this with opioid use. So again, the question is, okay, that's great. It seems to work for some other things, but can it help with opioid tapering? And that's where our pilot study comes into play. So I'll tell you more about our study. Why are we doing a pilot study? So generally, when we're doing clinical research, you know, you do have to kind of have a proof of concept. And I would say it's important to do lots of pilot studies in this field because of the degree of oppression, prohibition, and stigma associated with this work. Especially in the addictions realm. I have come across it again and again that there's a culture that is pretty hostile to the idea of using a drug experience to treat problematic substance use. And that's going to be a barrier to overcome if we want to do this more. And again, this is the very first time anyone's used psilocybin in such an intervention with this particular patient group. So a pilot study is very important to establish that this is safe. It's not overly burdensome to the participants or the providers, and that there's some indication that this is more effective than other methods. Another reason for a pilot study with limited funding, it's very hard to do a very big, expensive study based on donations alone. So that might be another reason why we're getting lots of pilot studies right now. It's hard to get that kind of funding. So our trial is an open label pilot trial. So that means that all participants, it's a single arm, they're all getting psilocybin, there's no placebo control. We're going to recruit 10 patients from the Bill and Melinda's Pain Clinic. So that's here in Kelowna. And we're specifically recruiting people who have tried like the other available means. They have failed previous attempts to taper their opioids, and they're considered treatment resistant. Our approach combines the psychological intervention with their normal care at the pain clinic with the add-on of a high-dose psilocybin session. It's 1 or 2 doses, and I'll show you the structure in a moment. As far as the status, we have regulatory approvals in place from Health Canada, and we are in the very final stages of REB approval. And I mean that. I just submitted the last requested proviso that they asked, which was basically a typo of something I did before. So we're really optimistic that in the next few days even that we could get approval and start recruiting as soon as possible. As far as our therapeutic approach, we're using the typical recipe for psychedelic-assisted therapy. And so that's the dosing session is sandwiched and supported by psychotherapy without medicine to prepare them for the experience and to help integrate and make sense of the experience as well. Now we are complicating things further by adding on a medically supervised opioid taper during this process. So we're also using the psychotherapy to support them as they reduce their opioids. Now, each psychedelic-assisted therapy trial has a different sort of model of therapy they're using. We're using acceptance and commitment therapy to inform our approach. This is considered a third wave behavioral therapy, which really means it's the shift from therapies that focus on thoughts and cognitions to focusing more on experiences. And we feel this is really in line with the philosophy of psychedelics, with the experience itself. With chronic pain patients, we really want to encourage them to move away from avoidance and come to accept their current experience, their pain, and to live life more in line with their values. If you want to see a really great paper talking about the proposed mechanism of mindfulness, see the paper by Walsh and Tyson, 2018. So this is our study. So you'll see at the very top, we have medical and psychological screening. So people who are eligible screen in, and we start doing preparation work with them. At week 3, we have our first large dose psilocybin session. So 25 milligrams is the standard so pharmaceutical psilocybin, right? Standard synthesized or extracted dose. It equates to probably about 3.5 grams of mushrooms, depends on who you ask. Now, they only have to do 1 large dose session to complete the trial. They have to do all the integration and prep, but the second dose is optional. So at week 7, we have a second larger dose. And the purpose of this is we don't want them to have to do it because in my experience working in these clinical trials, I've noticed that some people have very profound experience at 25 milligrams. Some people have a very underwhelming experience. Some people, depending on the changes they want to make, might need a second dose. So we wanted to keep it a little bit flexible here. You'll see the red opioid taper begins at week 4, and participants meet with their physician every week or every 2 weeks basically to start lowering their dose. And they gradually lower their dose, and the goal is by the 6-month mark that everyone's completely off opioids. So we offer optional integration sessions kind of later in the trial. So if anyone needs more support, they can, and we follow them up for 6 months. Here's some of the things we want to look at. So basically our 2 aims, right, remember, is we want to make sure that it's safe. And we also want to see if it's feasible. So safe, feasible, and also, is there some indication that this is effective? Is it worthwhile pursuing further? So first, is it well tolerated and safe? To do this, we're going to monitor serious adverse events. Serious means hospitalized or death, essentially. So we expect 0 incidents, and we really don't expect there to be even one. There hasn't been so far in research trials, but we never know. We also expect mild adverse events, the typical side effects that are reported in these trials at a normal rate. We also expect participants to, they're going to be rating their perceptions of the treatment. So we expect them to rate it as being at least more beneficial than harmful. We also hypothesize that our treatment's going to facilitate successful opioid tapering in most patients. And remember, these are people who have failed before. So we're really hoping that this will help. Our hypothesis is that 7 out of 10 will be adhering to their taper schedule at 1 and 3 month follow-ups. That means they'll have reduced by probably 70 and 50% at least at that point. And that by the end of the trial, at least 70% will have successfully completed their taper, meaning they're at 0% of their starting dose. We also hypothesize that we will see some improvements in relevant psychological mechanisms. And what I mean by that is we expect them to experience increased mindfulness, more flexibility, better quality of life related to sleep, and also that they'll feel more in control of their use of opioids. We also expect to see a decrease in their cravings and their withdrawal, and with some of those problematic symptoms that we talked about before that can be real barriers to successful tapering. So that's pain, depression, anxiety, and some of the cognitive distortions. As a result of this work, we hope to learn a whole bunch of things. We hope to learn that it's safe or that's not. And we also want to know if it's more effective than standard tapering protocols, which, as you might remember, were about 50% or less success rate. And although our primary target is opioid use, we're also wondering if it could improve the pain-related outcomes, like sleep and depression, anxiety, those kinds of things. We also need to know, like, is this practical? Like, really, is this, when we implement this in some kind of outpatient clinic, is it going to be overly burdensome on the providers or the patients? Is it feasible to do this on a broader scale? And we also want to know if there's potential for expansion into larger trials. And by that point, we could look at doing placebo control or some kind of variation, so that we can look at some of the mechanisms for the therapy. And that's really it. So I wanted to thank you all so much for your time and attention tonight. And I'd like to leave the rest of the time open for discussion and questions. Thank you.
Thank you so much for an excellent presentation. I'm so excited to see where this goes, and like, congratulations on putting hopefully what is the last step in submitting ethics.
We'll see. Yeah, thank you.
Yeah, if anyone has any questions, please raise your hand and go ahead. Monique, yes.
Thanks for a great talk. I'm sorry if I missed this. I noticed, so the second dose that you guys are providing potentially as I guess an option was 37.5 milligrams. And I'm curious about that because I haven't seen that dose in other studies. And I wondered, maybe this is like a secondary to that question about the perceived or the potential interaction between opioids and psilocybin. It's something I've been wondering about because opioids have serotonergic activity. And so I'm wondering whether you guys are using that higher dose to sort of overcome the serotonergic tolerance, I guess, or if there was another reason, or if you're concerned about that potential interaction, drug-drug interaction.
Thanks, Monique. That's a really great question. So, I mean, some of this is a little bit unknown because, like I said, this is the first time that this has been implemented in a study with this population. So, I think your question would be like really well directed to our qualified investigator, the physician, who knows a lot more about the medication interactions. But when we were kind of cooking this up, I had a similar question for him, and that's what's the interaction between the two? And he said, no, it's absolutely safe. And that we would be monitoring them very, very closely over the entire study period. So if there were any serious adverse events that came about and we thought it was related to that, we would definitely stop what we're doing. But in talking to him, no, there's no issues being raised about possible serotonergic issues with it. That wasn't actually why we wanted to offer the higher dose. It really was because a number of us are working in other trials, and as we dose people with the 25 milligrams, like I said, some people don't have a very like pronounced response to it and come out of it being like, I wanted a lot more out of that. And that seems to be reported across a number of studies. And actually, some of the other trials do have, I think it would be at the second or third dose. Some of them have like a 3-dose regimen where they have that optional higher dose as well. I have to look into which ones those were, but I think the Johns Hopkins one had the higher dose. I think some of the depression trials did too. And maybe that is because of the serotonin issue if they're on like a medication. That's a great question though.
Thank you.
Yeah, that's kind of one of the questions that I had was about like running into issues potentially when proposing, to give psilocybin to people who are on opioids. Was there like resistance that you faced to sort of that idea?
No, actually, neither from Health Canada nor the Ethics Board. Lisa?
Yeah. Hi, Tashia. Great
Hey.
talk. Hey. So, given that previous research has shown people can have really profound experiences and a lot of change could come out of just one psilocybin therapy, I'm wondering whether your opinion on whether somebody might want to completely quit the opiates after the session, and what's the likelihood, and if so, is there a mechanism by which they can do so within the tapering schedule?
So you're wondering if someone might decide that they don't want to do the gradual taper, that they just want to like completely stop?
That's right.
Interesting. I think that's not something I'd thought of. It's certainly a possibility. Like the work I've done in the alcohol use disorder trials, like you do get that sometimes people are like, they have a big realization. They're like, I'm done with this. I would say we would probably advise against it because we don't want them to experience intolerable withdrawal symptoms. We'd probably still advise them to do the gradual change, but encourage them to make changes in other areas of their life that support it. But I think it's a great question that I can bring to the team and find out like what would we do if someone insists that they're just going to stop? I mean, they're already under medical supervision. So I would imagine that would be a conversation they'd have with the study physician and they'd figure out how to support them that way.
Thanks. That's a great
Okay.
answer. It's very exciting work.
Thank you. Yeah, and as a side note, so the first kind of iteration of the design, we had originally made it 2 doses, some time apart, but the participants had to do both doses, like to make it through the protocol. And then with more experience in this field, we realized, no, there will be some people who don't want to do the second dose, and that doesn't mean they fail. That might actually mean that they're doing incredibly well at that point and don't need it. So then we sort of changed our design to make it more flexible and allow them that choice. Yes, Rick.
Hi there. Thank you very much for your talk. Much appreciated, very informative. I have a question relating to this study as compares perhaps to MAPS's MDMA-assisted psychotherapy for PTSD study, where about 2/3 of participants did benefit and no longer met clinical criteria for a diagnosis of PTSD. And, you know, there is that third that still met criteria for PTSD and who may or may not have benefited from more sessions with MDMA. So my question is, in this study, is there the option for participants to continue with more high-dose sessions of psilocybin if that were deemed needed?
That's a great question. I think, unfortunately, we are sort of limited by what we can do legally, similar to the participants in the MAPS trial. So I think if that were to happen, right? So if they kind of get through the study and they've done both doses, for instance, and they feel like they want more, the most that we could do is keep them on as therapy patients and support them that way. And I mean, it's up to individual people if they want to seek underground therapists or whatever at that point. We could support their application, I would say, at that point to the SAP program. So if those who don't know, it's the Special Access Program. So, you know, their physician could assist in an application to Health Canada to grant them an exemption to get extra psilocybin sessions. And I would imagine being through a clinical trial already and having that documentation that they need more, perhaps they would have a greater chance of getting it. Now, I do know most people that apply to SAP don't get approved yet. So it is really frustrating. And I hear you, and I don't think I have a great answer for that.
Yeah, no, I mean, I think that's the best answer that's available at this time. You know, I'll be curious to hear what your success rates are once this pilot study is done. And perhaps if there's any conversation thereafter about what potentially can be offered to people who don't have the success that's hoped for as a result of this trial, to potentially tweak how it's done going forward, or to potentially find funding to offer more sessions like that. So again, thank you very much for your talk. Very informative, and I look forward, you know, to seeing how the results turn out.
Thank you, Rick. I can't see who's next on mine.
I think that's Riel.
Sorry, I didn't change my name. It's Riel.
Oh, hi.
Hi. I am curious about the analysis. So there'll be some people who are having one dose and some who are having 2 doses. And I'm just wondering if that's going to be part of your analysis to see, you know, there's only 10 people, so I don't know, you know, how that will work with the numbers, but I'm just curious about that plan.
Yeah, no, that's a great question. So I think being so underpowered with only 10 people, we wouldn't be able to make like group distinctions statistically. I'd say most of our findings are going to be descriptive in nature, and the best we could do is sort of pre-post the entire intervention with most of them. But yeah, I'd say if we can at least show descriptively that there is a big difference. I don't even know how many people would want the second dose. It might just be 1 out of 10, right? So kind of depends how that pans out. But as far as planned analyses, we're not powered to really look at that, unfortunately.
Thank you.
Thank you. Jeff?
Yeah, thank you. So you talked about the role of pharmacological treatment for opioid use disorder. So do I understand they won't be using the traditional pharmaceutical treatments? They'll have the therapy and the psilocybin, but not other medical treatments?
That's a great question. So when we think of traditional pharmacotherapy for opioid use disorder, we're talking about methadone and buprenorphine. That's not actually they're primarily chronic pain patients. So if we think about that, they're being treated at a chronic pain clinic. So they're still getting their normal care there. And so they, as part of our protocol, at the discretion of the doctor, they could be added on some anti-inflammatories. They could be getting some other medications to assist, but are non-opioid. And I don't believe that any of them would be transitioned onto methadone or anything like that. Does that answer your question?
Yeah, thank you.
Okay, thank you. Hi, John.
Hi, thanks for the presentation. I'm really looking forward to the outcomes here. So, yeah, as you mentioned, you're getting your patients or your participants from a pain center. So they've been prescribed these opiates because they've experienced physical pain.
Mhm.
So as far as opiate use disorder in these individuals compared to, say, individuals that were using heroin for years, and comparing it to other use disorders like alcohol use disorder, for example, I'm just wondering the difference there, like how you tease out psilocybin and how it may be beneficial in treating an addiction or a use disorder versus are there any effects on the physical pain and how will that be looked at through the patients? If they're like the reports of physical pain, will those decrease or is it actually targeting just the opiate use disorder itself? And is there a way to really do that? To look
That's
to
a wonderful
differentiate those
question.
effects?
Yeah, again, so the statistical power issue. So with only 10 participants, it'll be really hard to like quantitatively tease that out. The best we can do is show the changes over time in the different measures. And our main outcome, like you said, is the change in consumption of opioids, right? So are they actually sticking to their taper? Have they reduced over time? Have they maintained the lower levels of use or abstinence from it? We're also measuring a number of chronic pain outcomes. So they're getting it many times or multiple times over the intervention, asking them how severe is your pain? How much does it interfere with your life? Also things like how much they avoid facing their pain. So avoidance and catastrophizing pain. All those are things we're going to look at over time. So perhaps we can kind of tease it out or at least see some trends. Let's say they're decreasing their opioid use, but their chronic pain levels are still high, then we might say, okay, it doesn't look like the psilocybin is actually helping the pain. But if it does also decrease, or let's say they keep using the opioids at a higher level and their pain decreases, then we say, okay, we're not sure if the psilocybin did anything or if they're just reverting back to opioid use. It's a great question. I think you touch on this issue of, these shared mechanisms between disorders. And, I work with people who are also, using sort of street fentanyl and are more the classic opioid use disorder patient. And most of them have severe physical pain that, either started them down that road or they've developed as a result of their lifestyle. It's so hard to tease this stuff apart. So I think it's a nice reason for us to look at both of it together, really.
Yeah, I think it's great. Even a pilot study, even to get like qualitative information reports from the patients is great, and that's going to be monitored as well.
Yeah,
Okay. So,
and we do have sort of a qualitative element. So at the end of the study, we do sort of an interview with them about kind of the most impactful parts about the study and that. So I think we're hoping to have a qualitative piece by the end too. So stay
okay.
tuned.
All right. Thanks.
Thank you.
One question that I had was about the like psychotherapy framework that you were discussing. So I've heard a little bit about like third wave approaches versus the cognitive behavioral approaches. And I'd love if you could just expand on that a little bit and sort of like what that would look like in the session.
Sure. So for anyone who's not super familiar with cognitive behavioral therapy, I mean, the name says it all, but you really are focusing on targeting cognitions, so distorted beliefs about oneself, and the focus is on the thoughts and the behaviors. With the sort of third wave therapies, the focus is more on direct experience, practicing mindfulness and attention to present moment. So actually, if I go back to that, if I can go back. So this diagram here, and in your own time, if you're not familiar with acceptance and commitment therapy, it's really interesting to look into, especially if you think about how some of these concepts really map on to the psychedelic experience. You can see some really direct correlations here. So for instance, cognitive diffusion, if I can explain in the context of this, would be like, I am not my thoughts or I am not my pain. And I think people who live with chronic pain for so long become so fused with the experience of pain that they're not detaching enough to sort of notice that they're experiencing pain. Like there isn't this, I am experiencing, it's like I'm in pain, or there is pain instead of like it hurts. So it's sort of getting people to observe their experience rather than to be totally immersed in it. And I know I'm not explaining it super duper well, but that's basically what we're going to be doing in the therapy sessions, is getting people to focus on their values, getting them to practice acceptance and more open-mindedness. And the medicine itself, is probably going to catalyze that kind of thinking a bit more and allow us to do that kind of work, is the idea. This approach was used, I think, mostly in the psilocybin for depression trials. To the best of my knowledge, I don't think it's been used for like addictive disorders just yet, but I think there's a lot of potential here for it.
All right, thank you. Does anyone else have any sort of final questions? Any comments?
Yeah, comments are welcome too, or anything that you're doing that's similar, or yeah, anything at all.
All right, everyone. Well, thank you so much. And thank you, Tashia, so much for presenting today. I really did enjoy like hearing about your upcoming study and how much progress has been made. So I just wanted to put this up and say that this is our website as well as our mailing list here. And I just wanted to ask everyone to consider donating to help MAPS Canada run these sessions. As the research room, we provide a free event, and it does take our resources to continue running these. So if you're able to and you would like, please go to mapscanada.org and consider donating to our organization. Yeah, thank you guys so much for coming out today.